Be alright.
Ta-da.
In the UK, some 5 million major operations are carried out every year.
It'll be absolutely fine. We'll take really good care of him.
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
Right, can I start?
Table is locked, we're good.
Nice, please.
Millimetres count. Your focus has to be perfect.
University Hospital Southampton pioneers techniques to treat conditions that few others dare to take on.
This is the sort of operation that you lose sleep over.
So that's the squeaky bum time.
You're always trying to push the boundaries of what's possible.
Every step needs to be done meticulously.
But being at the cutting edge of modern medicine comes with great risk.
This is the tricky bit.
Right, let's just get this right.
Sometimes we're a whisker away from failure.
The surgeons bear the ultimate responsibility.
Just worried it's going to crack the bone.
Sometimes it's surgery and things can change just like that.
You are very close to the things you don't want to cut.
If it were to bleed, its entire blood volume within a matter of minutes would bleed out.
Okay, everyone away. Shocking.
I have quite a number of cases that I have never, ever forgotten when something doesn't go well. And that stays with you forever.
It's just not right.
This is what really happens behind the closed doors of their operating theatres.
We've got the lump out.
Excellent work.
You can't really ever let your guard down.
Operation's all done.
It really is the difference between a patient making it through or not.
University Hospital Southampton is one of the country's largest hospitals, providing care for close to 3 million people. One of its leading consultants is surgeon Arjun Takar. Arjun specializes in treating serious liver and pancreatic conditions, known as hepatopancreaticobiliary, or HPB.
I was drawn to HPB surgery because I enjoy the technical aspects of doing complex operations. You need to have a significant skill level to do it. When I'm coming into work, I am rehearsing the steps of the procedure, making a mental map, what potential issues I might find, and how we would deal with them. So this is a lady who I saw in the Bournemouth clinic a few months ago.
Arjun's next operation is so challenging, he'll be joined by fellow HPB surgeon Tom Armstrong.
So scan is up here.
His patient has rare malignant neuroendocrine tumors, only diagnosed in 4,000 people each year. The tumors affect cells that release hormones into the bloodstream.
A neuroendocrine tumor is a growth which can be found in neuroendocrine tissue. More specifically, we find these tumors within the pancreas. Because they're slow growing, they get diagnosed quite late and they spread to other parts of the body.
The growth started in the pancreas, spread to the liver, and may have invaded the spleen.
The fact that she's got secondary cancers in her liver tells you that it's already moved on from the initial phase where it's simply confined to the organ. Because neuroendocrine tumors are slow growing, patients don't really have symptoms from them, which means that these tumors can be growing in the patient for a very long time, sometimes years.
If Arjun doesn't remove the tumors, they will continue to grow and eventually kill the patient.
The time to treat her is now, because if we didn't operate, the tumors in her liver might increase in number or size that we couldn't remove them.
Good girl.
Lisa is a 55-year-old single mum. Her tumors were discovered during an earlier operation.
You hear cancer and you just immediately start worrying about that. My first questions are, how long do I have?
During the previous procedure, a camera captured images of the growths on her liver.
This photo has kind of saved my life in a way, because we would have never have found the cancer without this. Because I feel so well and I don't have any symptoms. It's quite a strange feeling looking at it and thinking that's probably one of many that's sitting on my liver, and then my pancreas is probably even more covered than that. That's growing inside and has been growing for a very, very long time. I didn't want to tell a lot of my friends because I didn't want them to worry. So I kept quite a lot of information to myself. Writing a will suddenly became really important, and making sure that arrangements were in place. I have my son. He's really been at the forefront of my thinking about having this surgery. I need to be around for him. I'm not ready, and he's certainly not ready for me not to be here.
The secondary deposits are visible as these black spots, and there's another tumour at the back of the liver, and as we work our way up there are several smaller spots that you can just about see.
To remove as many of the tumours as possible, Arjun and Tom will perform a two-stage operation. First, they will mobilise the liver from its surrounding attachments. This allows the liver to be manoeuvred so the surgeons can access and remove as many tumours as possible. For the next stage, the surgeons must tie off the splenic artery, which supplies blood to the spleen and pancreas. This will prevent a life-threatening bleed when the spleen and tumour section of the pancreas are cut out.
So when we're thinking about this surgery, we have to very carefully weigh up the risks because there are some complications that can occur.
The stakes are astronomically high. There are some important blood vessels that are supplying blood to the part of the pancreas we want to remove. If you don't control the blood loss whilst you're doing an operation on the liver, you could have catastrophic bleeding. It really is the difference between a patient making it through or not.
Lisa has come to hospital with her friend Carol.
Right, we're going this way. The hopes I have for Lisa after the operation is that everything goes as well as it can and there's no complications. Lisa's chosen to have surgery because it's the best chance of giving her a much better quality of life long term.
Go on, you got this. Yeah. You got this.
It is feeling really real now.
See you later.
It'll be an anxious wait, and the next 24 hours probably will be pretty slow.
Yeah.
Hi, Lisa. You all set?
As set as I can be, I think is correct.
Good. So, plan is J-shaped incision, have a look inside and evaluate the disease. We've counted roughly 10 lesions in the liver.
Really? That many?
But most of them are pretty small. Whatever's visible in a safety margin is going to come out. And then once we're happy with that, we'll move on to the pancreas and the spleen. I think we're going to be taking away something like 50 to 60% of the pancreas.
Okay.
Lisa will be able to live without these organs.
Okay.
But as the spleen helps fight infection, she'll need to have vaccinations and take antibiotics for 2 years. It's 8:30 a.m. and operations are starting in most of Southampton's 41 theatres. In Theatre F, a team of 10 surgical staff are preparing for Lisa's procedure.
Morning.
Morning.
Okay, are we ready to team brief?
Yeah.
So the plan today is to do liver resection and then a distal pancreatectomy.
I'm quite anxious. I think I'm just still trying to kind of process everything.
You all set? Right, Lisa. Just hold your arm out for me. There you go.
I don't really know what the outcome of the surgery is going to be. I feel all of that is out of my control.
I'm going to give you a very large gin and tonic, okay?
Lisa's anaesthetist is liver specialist Sanjay Gupta.
So,
Oh, yeah, that's good.
is that kicking in? Yeah. Lovely. A bit more relaxed. There you go. That's it.
Whatever happens, don't let me die. My son is not ready for me to go. I don't care what you do. You have to keep me alive.
You're going to be absolutely fine. We'll take really good care of you. Deep breath in for me. Okay.
The liver holds 13% of the body's blood supply at any given time. So when it's cut, there's a risk it will bleed heavily.
Right, Karen, central line.
To reduce the risk, Sanjay will keep Lisa's hydration as low as possible. This will lower her blood volume, so the veins in her liver are less likely to bleed.
Uncontrolled blood loss can, of course, lead to the patient bleeding out and the heart simply just stopping and the patient could die.
Sanjay, all okay from your side?
So far, so good.
To begin, the surgeons make a 20-centimetre incision in Lisa's abdomen and cut through fat and tissue.
Most of us have been through difficult situations in the operating theatre. Because of the complex nature and the difficulties you can encounter whilst doing an operation, I tend to work out escape routes or escape plans if things go wrong. How will I escape if I run into trouble?
Just in there, thanks, yeah.
Retractors open up the incision to give the surgeons better access.
Could you just see if you can adjust that light down there, please?
Finally, to reach the liver, the surgeons cut through the tissue covering the abdominal organs.
And once we've freed this up, we'll be able to lift the liver a long way forward to access the tumours at the back of the liver.
Now they can use ultrasound to locate as many of the tumours as possible.
So there are some obvious ones, and there are some are palpable and some are not. There's one very obviously there.
Yeah.
And another one very obviously here. Yes. And there's another one just in here as well.
The scan confirms there are 10 liver tumours, some as large as 3.5 centimetres.
Yeah, you can see it. Yeah, okay. So apart from the lesions quite nicely demonstrated up there, nothing else really.
Nothing else to do.
Right, okay. Should we start marking?
Yeah. So Sanjay, I think we're going to start doing the liver now.
Sounds good.
All right.
Okay.
So the Cusa, please.
The surgeons use a cutting device called a Cusa, which uses ultrasonic waves that break up liver cells but keep blood vessels intact. Along with the tumours, Arjun must take a large margin around each one so no cancer cells are left behind.
There's two of them, aren't there, Tom? There's one there and then there's another one next to it.
He can take up to 70% of the liver, as it will regrow over time. The first tumour is out. But even though Lisa's blood volume is being kept low, her liver is still bleeding heavily.
Bleed, isn't she? It's just dribbling out. Okay, let's just leave that in there. You just try and keep it dry for us so that the diaphragm will work. Yeah. It's quite a lot of blood.
There is more bleeding. So the nightmare scenario would be that the blood loss has been so high that my anaesthetist is telling me to stop and my patient is unstable. We are going to have to do something to control the bleeding if we are to get all the other tumours out safely.
HPB is among 9 specialisms at Southampton, with many performing groundbreaking operations, like orthopaedic knee consultant Amir Qureshi, who carries out innovative procedures on patients with debilitating conditions.
I remember my third year medical school and I went to theatre for the first time and it happened to be a knee replacement. And it just seemed so amazing, very technical, very much you're doing something with your hands.
Because it's both legs, it presents a particular challenge.
That's right.
Amir's next operation is so complex, it's been 2 years in the planning.
This is how he is now.
An all-day procedure to correct a patient's bowed legs, where their bones are curving outward at a severe angle.
You could see the top of the shin bone is more wonky than normal, and then that has led to an overall bowing of his legs as he's grown older. So if we can realign him, it should take his pain away quite considerably.
Because the operation is so complicated, Amir is working with engineer Sam Grasso, who's helped plan the procedure.
So it's a bit more of a steep angle, and then we'll have just slightly below the cutting plane pin.
Okay, this is a significant operation. I've never done all 4 bones.
We've discussed all various methods and pros and cons. It's very difficult, so I have to be crystal clear as to what I want to achieve, what are my backup plans, and what assistance I need from everyone else to achieve it.
Without the operation, the patient's condition will only get worse.
And I'm worried that with the increasing pain he's having, he might get a stress fracture, so it's just too much and it just cracks.
It's a one-of-a-kind surgery, and the patient's last chance.
You okay? Do you want me to take Benji?
I'm fine for now.
42-year-old Bruno was born in Madeira and now lives in Jersey with his wife and teenage son.
If I look back 3 years ago, I probably wouldn't think that I would be in this situation. I've always been a very active person.
Bruno has lived his entire life with bowed legs, likely an inherited condition. But over time, the weight of his body has put pressure on his bones, making the outward angles even more extreme.
Physically, it's a tremendous challenge for me. It's extremely difficult to accept that I'm not capable of doing things. The constant pain drains you and it takes a great effect on you.
Come on, it's okay. Don't worry about it.
Watching Bruno's decline has been hard for his wife, Nilza.
I feel that I don't know how to support him some days. You know, I can't take the pain away from him, which I want to. Seeing him in pain kills me and everyone around him. I miss the Bruno that was there at one point.
Okay, keep going, don't stop.
Bruno's pain forced him to give up his work as a chef and even sidelined his favourite hobby.
I've played football all my life. Football was my religion. I tried to pass that on to Adrian. I always trying to influence him. I used to coach a senior club, but I had to stop. Hopefully, I will be back doing what I was doing before.
I'm hoping after recovery, Bruno will be able to enjoy himself and not being in agony. So I can see this surgery as hope for a better future.
What do you think's going to happen when I have my surgery?
You're going to come back stronger and better than what you are.
It is a substantial operation.
Because the angle of Bruno's legs is so severe, Amir will make corrections to 4 different bones.
If we keep that part straight, we just got to move this across that way.
To straighten Bruno's legs, Amir will need to add a wedge of donor bone to both tibias and remove a wedge of bone from both femurs. On each tibia, Amir must first place a guide wire to follow when he saws into the bone. Then he will add a second guide wire that will act as a backstop. So when he saws into the bone, it will stop him cutting all the way through. Once the bone has been cut, he must gently prise it open without snapping it, before adding in a section of donor bone. On each femur, he will again use guide wires to mark where he needs to cut and act as a backstop. But here, he must cut out a wedge of bone and close the gap. Then use plates to hold all 4 corrections in place.
My top concern is I've got to make sure that the saw blade doesn't cut through the bone.
This is an operation that requires precision. even 3-4 millimeters out will make a huge difference to the correction.
So this is the current knee before any surgery.
To ensure every cut is precise, engineer Sam has built 3D replicas of Bruno's bones and created cutting guides, known as jigs.
So this is the first jig that we're going to use.
The jigs will be placed on top of Bruno's bones during the operation and guide Amir's cuts.
So this is the left knee on the tibia. So this jig really helps you to position that cut and position the plate.
This reduces the margin of error and gives me better accuracy to achieve what we've discussed and planned.
Because Amir will operate on 4 separate bones, the physical trauma carries significant risk.
The very fact that I'll be cutting through so much tissue, causing cuts and breaks in the bone, that in itself can overwhelm the lungs and the kidneys and the heart. So physiologically, getting him through the operation is something that is concerning. If at any time your body's not reacting well, or I have a complication, that means I've got to deal with that complication. We stop at that point. Is that okay?
I respect that.
All right.
I hope you have one of the best days at your job.
It's going to be the bestest. All right.
I hope you have
Okay.
the best day.
See you afterwards. Thank you.
In Theatre E, a team of 15 surgical staff are preparing for Bruno's surgery.
All right. So we've got Bruno, who's 42, and he's got quite significant deformities in both his legs.
I'm nervous, anxious, because I want to get out of this world that I'm enclosed into. Morning.
If you could sit down here behind this.
I want you to go with the flow at the moment. Go with the flow. Well
I'm delivering myself to you.
Yes.
I trust you.
Yeah. And we are going to look after you.
I need this.
Yeah. There we go. Ready, steady, slide.
Amir will begin on the left shin bone, or tibia, where he'll insert a wedge of bone.
Coming into the operation, I do feel responsibility. Bruno is expecting great things, and that does weigh on me as a surgeon. Karina starting?
Yes,
happy
thank
everyone?
you.
Emma, Jack? Yep, happy.
Amir makes a 10-centimetre incision and cuts through tissue and fat to reach the tibia, the second largest bone in the body.
Right, first jig, please.
After months of planning, it's now time for Amir to try his first cutting guide, known as a jig.
Just got to get the rotation right, please.
With the jig in position, Amir uses it to place a guide wire which will act as a backstop, preventing him from cutting all the way through the bone.
Tough bone. Precision is everything in this procedure, because unless you're precise, the overall result will be different to what you wanted. X-ray, please. It looks like it's going where it should be. And again.
As extra insurance, Amir compares his work to pre-op diagrams created from the 3D models.
Right, now we've got to take this off. Right, next jig. Yeah, shall we flex up again, please, team?
A new jig is used to place a second wire, which will guide Amir's cuts.
This needs to go down. I think that looks okay. Let's extend. That looks about right there, doesn't it?
Yep.
Picture there, please.
Yep.
Yeah, happy? Good. Right, thanks. Precision source.
Now is the ultimate test of the jig. Amir must saw into the bone and wedge it open, but leave a 16mm hinge at the back.
I'm going to cut the bone across, but not all the way. It's only if I partially cut the bone that I can hinge it open or close. If I break the bone all the way across, you would need to make another incision on the other side where all the big major nerve goes, muscle goes, and an artery goes.
But repairing a break would put Bruno's body under so much strain, Amir would have to stop the operation.
Because I need to deliver him back to his family safe and sound in one piece.
In Theatre F,
You probably put a swab on it.
Arjun and Tom are excising tumours from Lisa's liver. But after removing just one, her liver is bleeding more than they hoped.
Okay, let's just leave that in there and just keep going. So,
If Lisa loses too much blood, her life could be in danger. But anaesthetist Sanjay has exhausted all options to control it.
We've done all that we can to reduce the amount of bleeding from an anaesthetic point of view. So the next step would be a surgical intervention in terms of clamping the inflow of the blood supply to the liver itself.
I just think that we're going to need to probably clamp. Shall we give it a go?
Yes. So we're going to clamp, Sanjay?
Okay.
By clamping, the surgeons will stop the liver's blood supply.
The dilemma we have now is that we want to reduce the blood loss. But that means that we are going to have to deprive the liver of vital oxygen by putting a clamp across it.
Right, Sanjay, 10 minutes, please.
Yeah.
Right. Clamp is going on now, thanks.
Arjun and Tom need to remove the tumours with great efficiency. If the liver is without oxygenated blood for too long, it could be damaged.
Normally, we will clamp for 10 minutes and then give the liver a break for 5 minutes. The purpose of this is that the 10-minute clamp allows you to do the operation. You then give the liver its blood supply back for 5 minutes to allow it to recover, and then you go back into a 10-minute clamp again.
How many minutes have you got us on, Sanjay?
We've had 3 so far.
Great. Time, Sanjay.
Time's now 5.5.
Okay, good. With excessive clamps on the liver, you can alter the liver's function, its ability to clot the blood, ability to clear toxins in the body can be impaired because it suffered a significant period of clamping. So you're against the clock.
Good. Okay, here's another one. Yep, okay.
What we'll do is we'll just stop for a moment, I think. So let's just take the clamp off.
The surgeons have been operating for almost 2 hours, but only 3 tumours have been removed.
You do feel anxiety because you want to get this done, you want to get it right, you want to do what you had set out to do.
After 5 minutes of recovery, the surgeons can clamp the blood supply again.
Clamp is on, Sanjay.
Forceps to me, please.
Lovely. Well done.
To stem the bleeding, the surgeons cauterise the blood vessels as the tumours are removed.
Okay. Sanjay, time, please.
We've had 8.5.
Just that bit there.
That's 11 minutes now.
Okay.
The clock has run out. The liver's been clamped for more than 10 minutes.
Should we give Sanjay the liver back? Clamp is off, Sanjay.
Thank you.
Arjun and Tom have managed to remove 9 tumours.
There is also something slightly deeper inside there.
Yeah.
But there's one they haven't been able to reach.
There's at least one small, deep lesion that we're going to leave behind. because we would need to remove a very major part of the liver to take that small tumour.
The last tumour will be treated at a later date using a needle-like probe that will use heat to destroy the cancer.
All done except for the one lesion deeper. Yeah.
Basically, it looks like a Swiss cheese at the end of it. Lots and lots of holes in the liver.
Even though the surgeons have removed 10% of Lisa's liver, it can still function normally and will eventually regrow.
So we're going to start giving the patient some more fluid now.
Sanjay, how are you doing with filling?
Filling's good, it's coming along slowly. Tolerated the clamp pretty well.
Good.
So at this stage, it's really important that we rehydrate Lisa by giving her more and more IV fluids to make sure that whatever liver we have is well hydrated and well perfused.
So long as we don't lose any more blood, it'll be fine.
Yeah.
Yep, can we have a sidebar, thank you?
After 5 hours, the surgeons can start to remove the section of pancreas containing the egg-sized tumour, as well as the spleen, which could potentially contain cancer.
Can you see that? There's a tumour. The reasonable sized thing. You've got a slight bit of attachment here to the colon, which we're just working our way around. There we go.
But in order to remove the organs, Arjun needs to locate and tie off their blood supply.
But I think the splenic is sitting underneath the body of the pancreas, which I think is going to be slightly challenging for us to get to.
I want to get and control and tie off the splenic artery because this is supplying blood to the pancreas and the spleen. I've been in instances where during an operation the splenic artery has been damaged and there is uncontrolled bleeding. I have the potential of massive blood loss. You could lose a couple of litres in a few minutes.
Just there, a bit of that. It's a vein of some sort.
But finding Lisa's splenic artery is proving difficult.
What we're seeing is an artery that's actually buried into the side of the pancreas, which is making it quite difficult for me to get to it. If I can't get to the splenic artery, I can't really do the operation.
When tumours like Lisa's are removed in Southampton's theatres, many are sent to be analysed at an ambitious on-site project to develop a non-surgical cure for cancer.
So we're going to cut up the tumour into small pieces.
Professor Mark Cragg is part of a team of over 100 scientists at the UK's first cancer immunology centre, developing treatments to encourage the patient's own body to fight the disease.
Work in cancer immunology is really important because it gives us the opportunity to use the immune system to treat cancer and brings us the potential that actually we can immunise people against their own cancers, which means they won't come back. Cancer immunology is a real advantage over some other treatments where we see tumour regressions and people relapsing from cancer.
The process starts by breaking down each tumour.
Here we have samples of our tumour. Now it's been separated into individual single cells.
Mark then uses a machine which employs lasers to analyse the material and identify immune cells that are lying dormant and failing to attack the cancer.
So on this one, we can see that we've got a proportion of immune cells called T cells. Once we've worked out which immune cells are in the tumour, that allows us then to think about designing new antibodies to target those cells.
The aim is to find the right antibodies that either attack a specific cancer directly or encourage the immune cells to do the job.
Last year alone, we made over 300 different antibodies. One of the holy grails is for us to develop an antibody that will be able to treat a whole number of different cancers.
More than 20% of immunology patients are now living cancer-free lives because antibodies have boosted their immune cells.
So what we can see is the immune cell here capturing a tumour cell and engulfing it and going off to destroy it. But it only does that because there's an antibody in the system. So an antibody is like a guided missile. It will target something very specifically, allowing then the immune system to detect that and then destroy it.
Mark has been working in this field for over 25 years.
There's a real sense of pride from working in cancer research. I'd be very proud if the drugs and the antibodies we're making go on to cure patients that have cancer. My dad died when I was very young from leukemia. So eliminating cancer would be a fantastic achievement.
In Theatre E,
Just put your hand at the back of it.
Amir is operating to fix Bruno's bowed legs.
X-ray there, thanks.
To make the first correction, Amir has cut into the left tibia and is gently chiseling the bone to prise it open.
If you're too gung-ho, then you could cause a complication where you crack the bone.
And again, please.
If Amir snaps the bone in two, the additional surgery to repair it could lead to an extreme inflammatory response that would be life-threatening.
Inflammation goes to the lungs, they get congested. That then leads to heart failure and other organ failure.
Right. Can I have the laminar spreader, please?
Amir gently opens the gap for the wedge.
I think we've got enough there. Right, and plate, please.
Amir thinks he's wedged the bone enough. Now he needs a plate to hold the bone in place.
You all right there, Jack?
Yep, almost done.
To fill the gap created, a wedge of donor bone is cut to size.
Donated bone isn't like a kidney or a heart or lungs, because the way that it's processed, all the blood material has been taken out of it, and your body very, very rarely will reject it.
So let's flex up a bit so the soft tissue gets out of the way. Yeah. Okay, thank you. Okay, if you come out, gently. Nicely prepared graft, Jack. Well done.
Bruno's existing bone will eventually fuse with the donor bone in the next 6 to 12 months.
The gap has been filled and the wedge has slotted perfectly.
Hopefully now, when we get an X-ray, it'll be like nothing's happened. X-ray there, thanks. Excellent. Right, let's put the rest of the screws in and the one side is done.
While the first correction is complete, Amir's work is far from over.
Right. Jig number 1, please.
Now he must repeat the process on Bruno's right tibia, using a new jig or cutting guide, modelled on that bone.
It's quite a thick cut.
A thick one?
Yeah, it's quite thick. Can I...
We got the connival. Is this the right model?
Amir doesn't think the jig is positioned correctly.
The way that the jig is sitting, my worry is that that angled slot isn't exactly matching to what I would consider a safe angle.
See, that just looks small. That's a big cut. Can I have the ruler?
He's concerned the jig will make him cut too close to the top of the bone, creating a weak and fragile correction.
As we look at it, it should come up to there. Where's the plate sitting?
When you see a 3D plastic model, the jig will just stick to it. But in real life, you've got fat, you've got a bit of blood, and you've got tissue, so it's more slippery. And just 2-3 mils either way will make a big difference to the correction.
I'm just going to extend that up a bit and do less of a shallow cut. Can I have an osteotome, the 15?
Amir decides he can still use the jig, but needs to slightly alter the angle.
This is going to get in the way.
But now there's another problem. The jig's new position is preventing the saw from entering the slot.
You have to go inside the slot.
Yeah, so I can't go inside the slot.
So that pin's going to have to come out.
Yep.
Can we take the pin out?
I think that one's in the way as well.
No, let's just take this off. I don't think it's helping anymore.
I don't feel that this is right, so I resort to going freehand.
for like giving me a bit of a template.
Above all, a surgeon needs to be competent and experienced. And aids and jigs and templates are aids and jigs and templates. You have to know when you have to take over.
Amir decides to abandon the jig and use his own judgment and skill.
It only takes a tiny difference, and then the final thing isn't as you planned it. That will lead to me making an error and complication that will make Bruno worse.
This side is through. I'm not sure this corner's quite through.
No.
He needs to saw and wedge the bone apart without cutting all the way through.
Can I have a narrow one? 15. Thank you.
Finally, Amir thinks he's created the right amount of space for the section of donor bone that will correct the angle of Bruno's leg.
I just had to go freehand. I just think that if I'd used the jigs, I was just worried it was going to crack the bone. Look at that.
After 6 hours operating, Amir has completed the second tibia, again, without cutting the bone in two.
We've done both shin bones, but I'm mindful of the fact that we're only halfway through. There's still 2 more bones, the femurs, to do. It's incredibly important to stay focused because a momentary lapse of concentration is all it can take to have a significant complication.
In Theatre F,
I think it's just sitting underneath rather than on the side of it.
Arjun and Tom are trying to find and tie off Lisa's splenic artery so they can safely remove Lisa's spleen and the section of her pancreas containing the tumour. But Lisa's anatomy is making it hard to find.
Do you want me to try and hold it down?
Yep. And then the splenic artery is right now.
Oh, good.
Arjun has located the artery, but he still needs to navigate around it carefully to tie it off.
I can feel the splenic artery now, so it's very good.
Yeah.
And we start to feel it, see it.
Yeah, nice.
So if we come around the other side and then just make that tunnel, then we're happy, and then that splenic we can take straight after that. So now we're tying off the splenic artery. It's going to help us in 2 ways: reduce that blood flow because we can't take the specimen out otherwise.
Yep.
Scissors, thank you. Okay, good. Right.
With the artery tied off, Arjun now needs to decide how much of the pancreas to cut away, so no cancer cells are left behind.
Would it be easier to come from here to here?
Yes, that should be okay.
So in cancer surgery, we are obsessed with the surgical margin. You want a gap of healthy tissue between where the tumour is and where you make your cut. If you don't get a good margin, then potentially you're leaving tumour behind. You really do need to remove the tumour completely.
Yeah, I think we're probably good to go.
To remove the tumour, Arjun must safely staple off the section of Lisa's pancreas where the mass is sitting without damaging the surrounding structures.
Yep, staple.
You're nearing the end of your operation, and especially in a pancreas operation, that is the most hazardous part of the operation because there's a tendency for surgeons to potentially speed up because they can reach the end point quicker. And we do the opposite, to really slow everything down, because if you get all of those bits right, you make sure that there isn't any damage to important vital structures.
Is it all the way across there, is it?
Yeah. Good margin. Okay, let's go for it. Good.
After almost 7 hours, Arjun can remove the spleen and the section of pancreas containing the tumour as one specimen.
Okay, that's the specimen. Here's your tumour, good margin, spleen. Right, we'll have a wash, please, thanks.
It will be several weeks before the surgeons get the pathology results that will show if they've removed all the cancer.
Sister, can I have a 4-row proline, thank you?
Now Arjun must carefully stitch the end of Lisa's remaining pancreas to ensure there are no fatal post-op complications.
If the end of the pancreas isn't closed properly, there's potential that it can leak pancreatic enzyme, and this is corrosive to the insides of the patient. They can potentially cause severe sepsis because of abscess formation and make the patient really very unwell.
That looks closed, is it? It's very nice, actually. Very good. Do we have a bit of wash around the liver, please? There's no bile leaking from any of these and there's no ongoing bleeding. It all looks pretty good, actually.
I think if everyone's happy, we're going to start to close. Drain suture, please, thanks.
Arjun and Tom have removed all but one small tumour in Lisa's liver.
The operation's over. We do have a plan to treat the remaining tumour in Lisa's liver within the next few months. What I'd really like to see in the weeks ahead when the results are back is that we've removed the pancreatic tumour in its entirety.
Lisa, hello. It's all finished.
Patients like Lisa frequently come to you at a time of great distress. So you do feel that responsibility of helping them. The satisfaction of doing a complex, difficult thing as part of a very skilled team. It's exhilarating, really. I really couldn't think of doing anything else.
It's late afternoon.
Could I have a couple of tissue holding forceps?
Amir and his team are in the final stages of the operation to correct Bruno's bowed legs.
5 forceps, please.
Having added bone to both tibias, Amir must now finish the correction by removing thin wedges of bone from both femurs, the body's strongest bones.
Can I have the first jig, please?
Once again, Amir will use a jig to guide his cuts.
Okay, wire, please.
And place guide wires to ensure he doesn't break the bone in two.
X-ray, please.
Yeah, so this one here. So that should be sitting towards down here.
But the wires aren't entering at the correct angle.
That line is sort of in line with the notch, not the joint line.
So Amir needs to reposition the jig.
Let's take this up.
With the muscle being bigger on the femur, this is a tighter space with more forces against the jig to displace it. The quadriceps muscles is trying to force the jig off.
Get your diaphragm again, please.
To give the jig more space, Amir cuts away tissue around the bone.
Could you just, as far down as it goes, just hold that? Okay, no, right. Right, picture please.
Perfect.
Yeah, I think that's fine now, isn't it?
Yep.
With the jig finally sitting correctly, again Amir uses guide wires to give him a cutting line.
Picture there, thanks. I think that's...
Yeah, I think your
that's
rotation
fine. Yeah.
it's rotated as well,
Yeah,
so...
okay. Right, hold your turn, please.
Now Amir can cut out a thin wedge of bone.
Do a small clip. Good. I think now we'll just put the plate on and then let the plate just do its job.
With the plate positioned, he maneuvers the leg so he can close the gap where bone was removed.
Okay, gently, gently, gently. Right.
Before securing it with pins.
Top hammer, please. Okay, relax a second.
As in let go.
Yeah. X-ray, thanks. Yeah, that looks perfect now. Excellent.
3 out of 4.
Could the table go up just a bit, please?
After 8 hours in theatre and operations on 3 of Bruno's bones, Amir begins on the final one, the right femur.
Okay, Mac, can those scissors, please? Thank you.
No, good, actually.
Yeah, thank you.
The wedge of bone is out. Once again, Amir needs to close the gap and secure the position with a plate.
Where is it?
Here.
Can you see the hole?
No, but that's your line.
Yeah. Where's the hole?
So the hole is still covered.
But Amir and Registrar Emmett are finding it difficult to close the gap and make the plate sit over the screw holes.
All the time, I'm trying to close the bone. The bone is trying to recoil and open. There's a strong risk that the bone will just snap. So it's just that balance between resisting the recoil of the bone, yet putting enough pressure that the holes line up.
Do you want to come that side and put it in?
They swap sides, with Amir adjusting his grip on the leg.
So we're struggling to get access so that both there's pressure on the bone, so it's closing, and the plate is held in a way that the pins can go directly in the hole.
I take Nadi Mala, please. Thanks.
We hear a loud crack. This is either because a hinge is broken, or it could just be part of the closing, and often you do hear a crack.
Can you just move back with the x-ray, thanks? Okay, just put it in.
Amir won't know if the bone has snapped until he's seen an x-ray. But first he must finish placing the plate.
My priority is to get the bone stable by putting the screws in the plate, and then get an x-ray, and then deal with whatever the x-ray shows. Patience is the key word. So it's just keeping everyone nice and calm and just breathing through it.
Just needs to flip or to close down a bit more. It's just because they're not straight. Keep closing, keep closing, keep closing.
So what we'll do, we'll put this in, compress that. Right, final imaging.
Only an x-ray will reveal if they've snapped the bone in two.
The joint line looks good. That hinge looks fine.
Amir has successfully closed the gap without breaking the hinge and completed the corrections on all four bones.
So there is a sense of relief. There's a sense of satisfaction that all these years of planning, everything has come up to this point. It's all gone well.
Good. Lateral there, please. Table down, thank you.
The immediate surgical part is over, but his waking up, his recovery is outside of my control. So as a surgeon, this is where the anxiety starts.
Okay, Bruno, your operation is done, okay?
His wounds have got to heal. And then, of course, there's crutches and then hopefully walking by himself.
Yeah. You're welcome. Well done.
Seven weeks after Lisa's operation to remove tumours in her liver and pancreas.
Hiya, good to see you. Come on in. Come on in.
Thank you.
Come and have a seat.
She's returned with friend Carol to discover how successful the surgeons were.
The pancreatic tumour, as expected, was about 6 centimetres in size. All the disease that we've removed, the growth rate is actually less than 1%. So even slower growing than what was thought initially.
Yeah, oh, that's good.
We ended up getting more liver lesions than we were expecting. So we think that we've only got one lesion in the liver left.
Okay, well, that's really good.
The plan is to put a needle into that and burn the disease away. So from my side, we're up to something like 97–98% of your disease is gone. And at the end of that, we would be looking at no visible disease.
That's really
Which
good.
is sort of what we were hoping for at the beginning, weren't we?
Yeah.
So yeah.
Thank you very much. They've done an amazing job. They've got, most of the cancer now. There will be some follow-up treatment still, but on the whole, no, it's really good news. I'm really pleased.
Whilst doing the operation, we had to review our plans, and because we did this, we were able to remove almost all of Lisa's tumours. To see a patient who's gone through a very big operation and looking healthy, in a good frame of mind, that she will return to normal life with her family and work, makes it quite justified and vindicates what you do.
Nine weeks after the surgery to straighten his bowed legs, Bruno is back at Southampton for his first post-op appointment with surgeon Amir Qureshi.
Bruno, do you want to come in?
Hello.
Good to
How
see
are
you.
you?
Come
Good
through.
to see you too.
Come through. How's it been for you?
It's been good. Desperate to get back on my feet.
Do you want to see the x-rays?
Desperate, please.
So this is how you were?
Yes.
And now?
Oh, wow.
So you're all straight?
Good job.
Good.
Thank you.
I'm really, really pleased with the way things are, and I hope you are.
You've made a big change in my life. There's stuff that I couldn't do with my legs that I can now, even though that I'm still healing. So for that, a million thank yous.
So now it's the next stage, and now it's time to start walking on this now.
Okay.
The x-rays look fine, everything's holding brilliantly, so you don't need to be scared.
Okay.
Let your body tell you when to take a rest, and don't force yourself.
Okay.
Do you want to try standing up now?
Absolutely.
Try walking?
Absolutely.
Let's see if we get you. Oh, look at that. Isn't that amazing?
Oh, wow, that felt good.
Happy enough to walk out?
Yes.
Say goodbye on you walking out?
Yes.
Go on.
This is your fault that I'm like this.
You feel your legs stronger, Bruno.
Yes. Thank you for everything. Thank you. Bye-bye.
It's a pleasure.
Today I feel like it's the beginning. I know it's just the early stage, but it gave me that little bit of hope that I can be the person that I was 6-7 years ago. Perhaps go back into doing a bit of coaching, going through the day's work without pain. All of that, I look forward for it.
The best thing about a high-stakes operation is that you can make an incredible impact to the patient's life. The hopes for Bruno going forwards is that he forgets that he's ever had anything done in a year and a half time. So he can just live his life and not have to think about his legs. And that will be the ultimate success, when he doesn't even remember he's had an operation.
Next time,
Things going okay?
It's delicate at the moment.
2 complex operations where success is not guaranteed.
No, that's super king.
We're in real trouble because there are no backup plans.
That will push the surgeons to the limit.
It's stressing me out.